It's not easy. I'm sure that all of you felt knee-jerk reactions to respond immediately when you're challenged, or perhaps you've already had to make a very difficult and tough decision in your life against great opposition. But as a leader, these situations will be nearly everyday occurrences. The key is to be able to remain calm, logical, gather the facts, get input from others, but also don't be paralyzed by analysis. Take yourself out of the situation emotionally and then ask a key question, and that is, what is the next right thing? And I can't thank you enough for asking me to do this talk, because it has caused me to do a lot of reflection since I was asked. And I think back to my career and how I drove back in '89 and '90. Anyone who's old enough to know what the industry was like then, I'm sure I drove my poor medical staff absolutely out of their minds. I know I did. And because I was wanting to do things that just weren't happening in the industry. You couldn't read about it in modern healthcare. You couldn't look to any other facilities. And I think that, that it really comes down to, for me, and that was instilled in me, I think, by Father Daniels, to always look at what the next right thing is. But obviously, what the next right thing is going to come down to your fundamental value system. So that brings me to advice number 3, which is be ready to make big decisions with courage. When it seems too overwhelming, just break it down and ask what's the next right thing to do. Not everyone's going to agree with what the next right thing is, and certainly, most definitely, not everyone's going to agree with you. But this is why acting from a place of courage, a place where if you know yourself and you'll be confident that the action you're taking is the right course because you know it's the right thing to do. People will question your decisions. They may do far more than that, but the key is focusing on the next right thing. When I began at Mercy, all of the physicians in the hospital, which is, I would say, virtually at 100% of hospitals at that time in 1990 that had admitting privileges, clinicians had privileges to admit patients to the ICU, right? They have voluntary privileges. They're an internist. They have a patient who they need to admit to the ICU. They admit the patient. They take care of them. The problem is that, as I found out shortly after I started at Mercy, a young nurse came into my office and told me about one of our internists, who's a good internist, who had tried to intubate a young woman to have a tragic and deadly outcome that really shouldn't have been necessary. And, you know, in Wisconsin, like most states, they simply give a medical license to medical school graduates for the practice of medicine and surgery, and they don't differentiate between specialty training. That's for medical societies to do and for hospitals to do. So again, for physicians to have ICU privileges back 25 years ago was the norm. You'll still see that often today. But what I decided to do was, when I looked at it, was I said, you know, he's a good clinician, he's a good internist, as good as any of the other interns. The problem is that any of those guys don't get enough cases a year admitted to an ICU where the procedures that have to be done, they can keep up any degree of real proficiency. So I decided that the right thing to do was to take the ICU. It wasn't a peer review question. I want to say that on this individual at all, because what he did, I'm sure, could happen to any of those internists for the frequency which they would have to carry out some of the ICU procedures. But I decided the right thing to do was to take the ICU privileges away from all physicians unless they had specialized training in ICU procedures, intensivists, surgeons, pulmonologists. There was a tremendous amount of controversy and resistance from the hospital medical staff because of the decision to take their privileges away to admit to the ICU. They could certainly follow the patient, but they had to turn over care to somebody who had specialized training, which meant they couldn't bill when they went to see the patient, right? And so they sued Mercy for taking their privileges away. And this happened in 1990. And the irony is, you know, we succeeded and the policy went into effect in 1990, or thereabouts in mid-1990. 10 years later, a group of Fortune 500 corporations got together and developed a leapfrog initiative demanding healthcare organizations they contracted with look at how to make major leaps forward in the quality of care offered in American hospitals. And so an intensive study was done. And after this intensive study, number one on the Leapfrog initiative list of how to make great strides quickly in the quality of care offered in American hospitals was to close the ICU to only those physicians who had specialized training in ICU procedures. So number one on my priority list 10 years before this was to do the same thing, and that is to provide a quality of care to our patients that could be elevated beyond what I was seeing happening. And but what I would say is that, you know, was I some kind of a genius in knowing to do this 10 years before the Leapfrog, even 25 years before even other hospitals today? I think Dr. Weckworth would be the first to quickly say, Bay's no genius. He would tell you that. But the fact is what allowed me to make that decision and to have the courage to stand up against the medical staff and really what the trend that was in the industry, the normal practice, was it was the right thing to do. I truly believe that, and it turned out obviously to be the case. I will say that 4 years after the Leapfrog, I was shocked to go to a nationally renowned hospital to visit a friend of mine. And if I named the hospital, you'd be just totally surprised. And they still had not taken the bold step to close the ICU to only those physicians who had specialized training in ICU procedures. And you might still find hospitals today who've not done that, and simply because the CEOs don't want to take on the resistance and the controversy with the medical staff for fear it could cost them their jobs. So in your career, though, your patients, your community members, and your associates are going to give you tremendous input and ideas on how to raise the level of care. And sometimes I've got my best ideas. In this case, it was from a young nurse who was brave enough to come walk into the CEO's office and tell me what had occurred, instead of letting it just kind of get swept under the peer review process and go away.